So I am grateful to be here with you, and I'm not sure how much you all know, what my role is going to be, but I'm going to be presenting 3 times to you in a series around stigma and how to plan for a reduction around that in your particular roles at the Commission. So I know that you guys are working on using the plan and using some of the strategy to really inform your work. And I know in both of those documents, there's a lot of interest in really looking at ways to reduce stigma and how important stigma is in really the significance of the disparities that you are experiencing in the different places you're working. So I'm going to do this for, I think I have an hour, yes? Oh, that was like a, yes, you kind of do. Yes, I do. I have an hour. And I'm going to have this be a bit interactive as well. So I want you to know that it's not just going to be me talking to you, but I'm going to have you guys do some things as well. So with that, I'm going to go. I'm going to start. So here's what I'm going to be talking about. I'm going to talk a bit about how does stigma get experienced in the different two different people. How is it being experienced in the communities that you're working with and in your lives? And how does stigma relate to the HIV-related disparities that you're seeing in the communities that you're working in? So I want to make a connection between stigma and the disparities that you're seeing in the different areas that you're working in. I also want to talk about responding to stigma at multiple levels. So what might be a response either at a individual level, at a structural level, at a provider level, and what might you do especially to support resilience, which is another way that you can mitigate stigma. So I'm going to talk about that. And then I'm going to talk about what you can do in your roles. And so you do have the PowerPoint handout in your packet. And you have a couple of other handouts that I'm going to refer to in a moment. We ready? You ready to go? Okay, good. So I know we're here in it says 2018, but we're in 2019. So what are you guys thinking? So stigma is a significant issue still? Yes? 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 Okay, yes. Okay, and it's been that way since the beginning, yes? And it seems even to me, and again, you can disagree with me, it seems even more so in many ways because of the chasm that has existed for people who are accessing services and those who aren't accessing services as a result to some of the stigma that they're experiencing. So I think that stigma in 2019 has a particular way in which it gets experienced, and probably a particular way in which it gets experienced in the different health districts that you guys are representing. Because I would imagine in one context it's one way, in another context it might feel a little bit, quite a bit different. So I want to talk a little bit about that. So here's just something I want you to tell me about. Here's a statement that you're making. I believe that reducing stigma is significant for me to be successful in my work. I'm thinking of the work at the Commission. If you say strongly agree, that's a 5, agree is a 4, not sure is a 3, disagree is a 2, strongly disagree is a 1, get a number. You got a number? It could be 3.75 if you want to do that. I know that some of you do those kinds of things. So who would be like a 5 or a 5? Who would say 5? Okay, well, who would say 4? Okay. So for somebody who's at 5, can you just tell me a little bit about why you said 5? Why would you say 5? Why is it you strongly agree that reducing stigma is a significant piece of your work to be successful? Why would you say that? Someone let me know. Yes, please.
So stigma prevents people from getting the services and the medical treatment that they need. So, and tested.
Okay. Anything else from another 5 person that wants to tell me why? Who said it's significant in their work?
I think stigma, sorry, over here. For us, stigma is also a barrier when we talk to legislators, when we talk to public bodies, trying to engage them in providing care in the ways that populations need, because people have preconceived notions about who those people are.
Right. So great, because you guys are both talking about kind of different aspects of how stigma impacts the work and creates disparities in the work that you're talking about. Anybody else who wants to tell me 4, 5, 3, 2 about what they why they think it's important in their work to be dedicated to a stigma reduction? Yes?
Well, first of all, I feel that reducing the stigma, people would feel more comfortable and authentic with their status or whatever illness or problems that they may have, the trust.
Right. No, thank you. Thank you for that. Thanks. So we're gonna talk a little bit about this, but I want to start with just defining it. Like, what is it? So again, if you guys had a word, what would be a word you'd use? What's a word for stigma? Just throw it out. Barrier. What else? Fear. What else? Shame. What else? Prejudice. What else? Anything else? What word would you use? Sting. Okay. So stigma, is a discrediting social label that changes how somebody's viewed. And some of that came from some work that happened in the 60s from Irving Goffman, but it's really about here that stigma is an attribute that links a person to an undesirable stereotype, leading other people to reduce that bearer from a whole and usual person to a tainted and discounted one. So people feel like there's a stain that they have, that there's a mark, that there's something that they've been reduced to by the stigma that exists. Yes? So it also has a way here, and this is from other research, of playing a key role in how and in reproducing relationships of power and control. So one of the things that stigma does, not only is it just create a way that somebody's labeled, but it creates chasms. It creates places where people are left out, people are discounted, people are disempowered as a result of it, and sometimes that is the reason why the stigma is actually happening. It's really getting a place of creating a hierarchy for the haves and have-nots. Yes? So it also can happen for different ways. It can happen to you because of who you are. So you can be stigmatized because you're black. You can be stigmatized because of your skin color. You could be stigmatized because of your sexual orientation. You could be stigmatized because of your gender identity. You could be stigmatized also because of behavior, something you've done, something that people don't feel like is a good thing to be doing. So it could be behavior. It can also be perception. It could be that you look like something that is not being valued in this community. You might have an appearance that also has that. So it could be identity, it could be behavior, it could be perception. It doesn't have to be accurate, but it gets leveled to you. So the other thing about this that I think is important is that there's an intersectionality that happens. It doesn't just come from one place. So stigma and intersectionality in this regard, I'm talking about the interdependence of multiple co-occurring devalued social identities. So if you have a devalued social identity, let's say it's around gender identity, and then you have a devalued social identity because it's about social economic status. Then you have a devalued identity and it's about HIV status. There's a way in which those are compounded, and sometimes people talk about layered stigma, sometimes people talk about compounded stigma, but I'm talking about an intersectionality in which stigma exists. And I would say, again, to this group, that for the most part, you are dealing with or working with or supporting communities who are having a lot of intersectionality with regard to the stigmas they're experiencing. Yes? Would that be yes? Would that be yes? I need a little amen at the moment. Yes. Okay, yes. Okay? And it makes it hard because sometimes people aren't understanding where the energy around stigma is coming from. And again, I'm going to give you an example of this, and it's going to be kind of general, so I don't mean to be that this is the way it is. But let's say that you're a white gay man. You might understand that the stigma is coming from your sexual orientation because of the way that it gets leveled at you. If you're a black gay man, you might not know where it's coming from because it might be because you're sitting in one context and it's because of race. You might be in another context and it's because of sexual orientation. You might be in another context and it's about HIV status in your own community. So there's ways in which people may not really get where that stigma is actually being leveled at them. And it can be exponential. So basically people are walking out into communities, into social spaces, and really anticipating that what's going to happen to them is they're going to be judged, they may be devalued, and they either do things to kind of change that, or avoid those places. So if we're talking about access, or we're talking about care, we're talking about treatment, you're talking about the things that you want to support, sometimes people are making conscious efforts not to engage because they don't want to feel that feeling. I want you to do something with me right now. I have little cards on your table. You have cards, and you also have cards on your tables too. Everybody, I think, should have a card, or they're near a card. I'm going to have you do something quickly about a stigma activity. So I just talked to you about the way that it could be coming from different sources. So it could be race, it could be ethnicity, it could be social, economic status. I talked a bit about that. And I would imagine that for all of the people in this room, that there have been times when they have felt the stigma experience. That someone devalued them, someone felt that they had an expectation that was lower than what would be expected of anybody as a result of who you are, what you look like, mental health status, incarceration history, something. So I'm going to ask you to do a couple of things with this. I want you, on the card that I gave you, I want you to think about an experience that you've had. It could be something that happened 25 years ago. It could be something that happened on the way here, where you felt like you were devalued, someone or something gave you that experience that you weren't welcome as a result of who you are. So I want you to think about that experience, and I want you to just write a little bit about how did you know that was happening? What was that? What were the things that gave you the clues or the cues that stigma was being leveled at you? What was happening? Was somebody saying something? Were you not welcome somewhere? Just write just a couple notes, because I'm going to have you speak to another person about the stigma experience that you have. So just think a little bit about what that was, and write a couple of notes. And some of you may have a difficult time thinking of one, and then other people may have like, oh my God, I had one, I have 10 of them I can think about right now. So just think about whatever that is. That'd be great. So I talked about the fact that there's societal stigma. There's a way in which there's prevailing values that certain people are valued, other people may be devalued based on a lot of different things. And through that, there's different ways in which people experience it. So in all of the literature, they either talk about self-stigma or internalized stigma, which basically means you take those messages that you've been given throughout, and you internalize them, and you either believe them about yourself or you enact those because that's really what people expect of you. So you get that, right? And I would imagine, again, when you're working with community and clients, you may see people who are experiencing internalized stigma because they're feeling that enough people have told them that they're not going to make it, or that they're going to be HIV positive, or whatever the thing is, that they're really just, in some ways, taking that on and creating maybe a self-fulfilling prophecy about some of the things that are expected of them. It can be psychologically damaging to people, and I think it's an important aspect when we're thinking, again, the reason why I'm saying this, when we're thinking about mounting a response, where do you want to focus your efforts? Are you wanting to focus your efforts on the person's individual and internalized or self-stigma, or something different? So I'm going to talk about other ways. So another one would be what I would call felt or anticipated stigma. So what happens is, again, if I've been in situations where I have been mistreated or devalued enough times, especially in the medical system, I'm just going to use the medical system for this moment, I'm anticipating every time I'm going to get there that it's going to happen. It may not be happening. You may be somebody who's very engaging, very welcoming, but I've had enough of it. And so if I've had enough of it, I'm going to anticipate that that's going to happen. And again, so behavior can happen where I might be somewhat distant from you because I'm already been hurt enough by it, or it could be something like I'm not even going to show up because I'm already expecting that thing. So anticipated stigma is another thing I think it's important. Felt has to do with the fact that it's actually happening and they're actually feeling the stigma. And the thing that just a little bit that I think is important is, even if you're anticipating something, you're still feeling it. You know what I mean? So you're still feeling the sting of it. The other thing that people talk about is enacted stigma. So basically, I think from the example that you gave, there's enacted stigma, which is actually the thing that's actually happening to you. The actual mistreatment, the judgment, the discrimination that's happening, that's enacted stigma. So that's what that means. And then the other thing is there's structural stigma. So there's laws, there's policies, there's regulations that create a discriminatory effect on people's access to services. So that as a result of feeling that these people might be devalued. So there's structural stigma, internalized stigma, self-stigma, which is internalized stigma, and enacted stigma. So the reason why I'm also saying that is I think that when you're talking about mounting a response, you want to look at like what are we trying to accomplish here. So the next thing is HIV stigma is just related to the unfavorable attitudes around people or people who are related to people who are living with HIV. So that's its own, when I said about intersectionality, HIV stigma is its own thing. It's its own level of stigma. And it could be that you're living with HIV. It could be that you're part of a group of people who are connected to people living with HIV. And the other thing I think is important about HIV-related stigma, it's disease stigma. So diseases are stigmatized anyway, and there are things that exacerbate the stigma that's experienced in a disease process. And those things are whether it's life-threatening, whether it's contagious, whether it's associated with a behavior, whether it's associated with moral fault, or whether it's visible. So those are the things that create it, that give it more juice. And so again, when you're thinking about a response to it, which one would you think would be the hardest one to make a change around attitudes of those things I just said? That it's life-threatening. Can you help people understand it's not life-threatening? Can you help people understand that it's not contagious in certain ways? Can you help people understand that it's not associated with particular behaviors? Can you help people understand that it's not associated with moral fault? What do you think would be the hardest one? What? I'm so sorry. Nobody won the prize so far yet. Yeah. So I would think it would be the morality, because I think that there's prevailing ways in which it says. So it's hard to change somebody's feeling about whether or not, if I said to you that I'm a person living with HIV and I've had 180 partners, there's a way in which that starts to create a different feeling around your support of me because of the moral fault that happens. So that's a harder thing to change. What is easier is giving people information about things like the contagion, the contagious nature of HIV. I know that, I'm going to talk about this in a moment, but I know that the Black Institute is doing something called Cut the Stigma. It's around barbers in the United States. And really giving people information about the fact that people living with HIV are not going to be in any kind of danger if you're cutting their hair, or and they could be there. And so you can change that stigma by giving people information about contagion, but it's hard sometimes because it's still that moral fault. But I don't like those people coming to me, or that part's a little bit harder. But anyway, I think that's important. So again, this is for the Medical Monitoring Project. There was a CDC fact sheet that they gave saying that about 8 in 10 patients with HIV are experiencing internalized stigma. That impacts how they either operate with regard to their medical treatment, that they're feeling dirty, that they feel shamed, and that's a pretty common feeling with many of the people that are engaging in the services. So internalized stigma is a significant thing for many people living with HIV. So just kind of laying the groundwork for you guys to think about how you'd respond. So the other thing that I think is important is to think about the connection that stigma has to HIV-related disparities. So before I tell you, what do you think the connection is? Give me a reason why you think. What's a connection you would make? There's disparities in the community and there's stigma. How does it connect? Anybody? How does it connect? People aren't being tested. People aren't being treated. Yeah, please.
One causes the other.
Okay, and say that a little bit more. Well, what one causes what?
The stigma causes the disparity, and the disparity enhances the stigma.
Okay. All right. So, anything else that anybody would say? Yeah, please.
Creates trauma.
It creates trauma. Okay.
Personal trauma, internal, and social.
Okay. Okay. So one of the things that I wanted to show you, and I gave you a handout about this, is an article that came out of, it was in the American Psychologist, and it was by Riley Earnshaw. I know that some people know who David Williams is. He's from Harvard. And what they were wanting to look at is to make a connection between stigma and HIV-related disparities, and to really kind of follow it along. Like, how does it happen that happens? Not just that people don't want to test, but what does stigma have to do with it? So they were looking at what I had just been talking about, social stigma, and looking at all of the intersectionality, HIV status, sexual orientation, gender identity, all of these things that are also a part of many people's experience. And they were recognizing that there has been, like if you go down to the bottom box that says individual level manifestations, that because of that people who are in the communities who are not, of those identities, the people who are perceiving these people, then end up with feelings of prejudice, feelings of stereotyping people, and discriminating people. So that happens as a result of the stigma that is leveled at particular people who may fall into those categories that are devalued. Is that making sense to people? So that happens, and as a result of the prejudice, the stereotypes, the discrimination, the person who is being discriminated against is either feeling in that middle box where it says individual level manifestation target, the person who's being targeted feels that they're either being perceived the stigma, they're anticipating the stigma, or it's being internalized because so many people have been telling them that. So they believe that. So that happens to them, and then as a result of that, risk is implicated. Incidence and screening is implicated, whether I'm testing or whether that's even happening. Treatment is affected, and survival rates are affected. So they were really looking at, and again, I can give you the article for this, but they were looking at how do these things actually relate to each other. And then if you look at the top level, which I think is really important, if you look at structural level stigma, due to things like institutionalized racism, there has been, residential segregation has happened in this country. And as a result of residential segregation, there are people who are not getting the same health care access that other people get because of where they're living and what's happening. That also has to do with who's living in what neighborhoods and who gets to actually get the treatment, or who gets to actually have the medical providers who are going to be able to respond to their needs. There's things like historical trauma assaults. Somebody just said something about there's historical trauma that's happened to many communities. So that's a structural level stigma that's been leveled at people throughout for generations. And there's medical mistrust, and I think many of you know that. Medical mistrust has happened from many generations too, because we were used as people to experiment things without even knowing that we were being used for that. And so medical mistrust is also a significant structural level stigma that has happened to many of a manifestation that's happened because of the history of our country. And so as a result of that, if you follow that box, as a result of that, again, I'm going to feel like when I walk into a clinic that I might be able to be, I'm going to be devalued because I know that has happened to people. So you're already kind of getting that, or that I'm internalizing that stigma, that maybe medical treatment isn't for me because I'm not going to be somebody you're going to respect. And that also then has something to do with the risk that I'm going to be involved in, the incidence rate in screening, because if I'm living in a particular community that has a lot more HIV, then I don't have to have a lot of, quote unquote, risk to get HIV. I think you know that. But I think that what they were doing with this, which I think is helpful, again, when we're talking to you all about how do you mount a response, is to think about where do you want to focus your attention to disrupt some of this disparity that's happening as a result of stigma. And so I'm going to tell you one other thing, because that's not the entire model. But what happens is, again, I gave you some examples of this, but risk is implicated because of like what I just said. There may be places that people are living that there's more HIV that's in the community. Testing could be implicated because there may not be testing sites, or people may be feeling like because they don't trust the system, they're not going to be tested. Those are some of the things. The same thing with treatment. And then with survival, people aren't really accessing care until later because of some of the structural level stigma that I just talked about. So the disparities related to HIV, and especially racial and ethnic, because I want to make sure that we're understanding that, because some of that is really about racial and ethnic disparities with HIV, because that's where some of that stigma is really leveled. So there's a connection there between that. Here's a quote that I think is important. Disentangling stigma from HIV risk infection and treatment is one of the greatest public health challenges of the 21st century. So one of the things that I think is difficult, and I'm hoping that even this first hour is going to be helpful for you, is to really kind of disentangle this, because that's a lot. Like, where do you even begin? Like, where do you start with this? Are you starting again with an individual? Are you starting again with a structural thing? Are you working with providers? What are you doing to kind of change that dynamic that's happening around stigma that's keeping people out of either prevention and care? So to change those dynamics, one of the things you might want to be looking at is, in a stigma reduction experience, where is going to be the focus of your attention? Is it going to be the individual clients to build their sense of support, their sense of empowerment around what's been happening in their communities? Are you working at more the provider-client level because you're recognizing that there's some difficulties with some of the providers to really be sensitive and skilled with particular communities? Are you looking at policy changes that would help to create better access for people who have been historically left out? Or are you looking at some sort of community intervention that would help people to know that HIV is in these communities and that we are all part of that and we need to respond? So that's one way that you kind of look at that. When I'm thinking about, I just said something a little bit about the Black AIDS Institute doing something called Cut the Stigma. So when I'm saying that, what they're doing is they're working with barbershops across the United States to give them more information about HIV, and so to change that dynamic that people would be pushed out of those situations. And really some of the reasons why that is that, and some of you all know this, but that's a space, that's like a, I don't know, I'd say sacred space, I'd say, for many men to really feel like they can really connect, can bond, can talk about their lives, can do this thing. And so to not have that social bond or not have that access to that really changes somebody's sense of self-worth, changes their self of, could they be part of this community? And so when I'm saying that's the intervention that they're doing, where would you think this falls on this? Is it a individual? Is it a structural? Is it a community? What is it? What is it? It could be all of them? Why do you say that? Say a little bit more, Susan.
Well, because ultimately it's an individual interaction between people, right?
Mm-hmm.
An environment that is sort of community institution, or like you said, like a sacred space or something like that.
Mm-hmm.
Right?
Mm-hmm. Mm-hmm. Anybody else? What would you say? That's good. No, that's actually fine, Susan. Because I actually think it does. It hits lots of different things. It hits the community. It hits the people who are actually going to be involved in those interactions, and so I think that's important. And it may change some of the policies that people have around. You can't, not cut somebody's hair because if they're having HIV. I mean, they really can change some other things. And I know that Black AIDS Institute was also working with Lambda Legal Defense around some of that. So that's an important thing. I think it has some policy implications. So the next thing is, the next thing is, this is just another example. There's something called the CAPAS Project, the Care and Prevention in the United States, and many of the projects were working on particular social determinants that they felt like had an impact on their disparities in their states or in their regions or in their cities. And this is something from Chicago, and it was called Protecting Our Patients. And they did some work really with providers, because they really felt like there was a lot of homophobia and transphobia that was happening on the provider level, and they were really wanting to make sure that they were engaging the community in a respectful way, and they really felt like the way that it was being not being respectful had to do more with the providers not really knowing or not understanding or making some assumptions about people. So they really did a whole project around that. And so that would be another example of like taking it at the provider level or the organizational level, rather than working with individuals to manage that stigma. So the other part of that diagram that I was starting to show you is in their work that they were doing when they were looking at the connection between HIV-related disparities and stigma. they were thinking about different things that you could do. Like, how could you reduce this? One of the things that they were recognizing, and even though I gave you some examples of things that were trying to mitigate the stigma that people are experiencing, is that stigma is such a significant power and a significant force that sometimes it's very difficult to feel like, okay, did I really make much headway with this? So some providers are feeling better, but are we really? There's still people are still walking out in the streets and having to deal with whatever else they're having to deal with. So the other part that they were saying in this particular, this particular article, and in particular in their work, was to really use resilience as a mediator. To feel like what are people doing to change that dynamic either on their own or in their communities, and really kind of bolster that and figure out what are people doing that actually has been working. Because I would imagine, when we just did this thing with you all and you talked about the stigmas that you've experienced, I didn't ask you this, but I would imagine that for some people it's like, okay, that used to happen to me, but I don't let it get to me like I used to let it get to me. And the reason why I don't let it get to me is what? I have social support, or I've learned other things about myself that that people said I was not going to make it, and I did make it. So there's things that you have used to kind of push yourself through and move through it. And so the other part of this that I think is more interesting to me, actually, personally, is to think about what you can do. And on this diagram, it talks about what are the moderators, what are the resilient resources that help people either at an individual level or at a structural level or at in what they call perceiver, but that's the provider level. What are the things that you can do to change that would make it so that people aren't experiencing the stigma in the significant way that they have been? So one of the things that I just want to make sure is clear is, if you're working on resilience, it relates to trying to challenge the stigma that's happening. But challenging the stigma that's happening doesn't always work on resilience. Does that make sense to you? So you really do want to know what is working for the communities. What are the things that people have done that actually have helped them to move forward? Because I know that you know that either from your own experiences or from the people that you work with and you deal with, that there's some themes around that might be also really helpful to make sure that that's included when you're talking about, I would say, that you're talking about a stigma reduction plan. And so for this, some of it had to do with, for a structural level, had to do with empowerment and trust. Like, how do you create more trusting environments for people? Or how does trust get created? How are people feel? How does that happen? They also talked about, for the provider level, what they're calling a perceiver, the people who have been maybe prejudging people. There are ways to kind of build what they're calling common in-group identity. So there's a way that you can actually feel like we're not so like my patients and me, that they're basically a way to kind of change that hierarchy by doing some things to make people feel more attuned or more affinity with the groups, and to create contact, opportunities for contact. So that, I don't know, I know that we started with this and I was impressed with, people saying, I've been living with HIV for 32 years and I've been living with HIV, And I think that there's a way that people just need to hear some of that and know that this is part of our community and part of our lives. And so I think that there's something about that I think is really helpful. And then the other thing is, but then I get to your question, is that for the people who are dealing with internalized stigma, part of the resilience has to do with really building or having them have those accesses to social support, the people who tell them that they're actually good the way they are, and also having them find what they're calling adaptive coping. So what's going to happen is, you're going to get, stigma's going to get leveled at you. How can you respond to this without it being something that's going to take you down even farther? So there's ways that you can use the resilient resources that people have either tried or used before to kind of mitigate it. Will you say something, Susan, please?
I had a question. I don't exactly know how it fits, but so I've been in this milieu for about 30 years, and as an activist and as a provider, right? Mm-hmm. And I think that my ideas, or other providers other people, whether they're HIV negative or positive, who've been around for a long time, about resilience might be very different than people who are recently seroconverted or new to this sort of arena, right? So as an example, I'm a provider who has been living with HIV for 30 years. You are a client who is my age, who just came in, recently seroconverted. To you, you might have a lot of resilience. You might be totally cool with it, right? To me, I see a failure, and I can't help that. I'm speaking generally, not as myself personally, but right, we're in the same community, living with the same virus,
Right.
but there is a stigma that could come from me, and I might not even know it, right? Because of my own sort of trauma.
Right.
And I don't think that really gets talked about very much.
No, I appreciate you saying that. It actually makes it complicated, but I think that there's ways in which all of us are carrying, like, we're not just the people who are the receivers of stigma. We're also people who are putting it out there to other people, you know, and sometimes you know it and sometimes you don't know it. Because I think the other thing that I think is good about what you just said and what we just did with that exercise is that, you know, when you guys said, you know, how did you know stigma was happening? You might have got a sense of how it was happening, but the person who was giving it to you may have not had no clue that that was how you were responding to that. They just were doing what they do, or they thought they were doing the right thing, or they thought they were, you know, doing what they were supposed to be doing. So, yeah, I think that there is something about that that I think is important to recognize. Like, how are we contributing to stigma, either in our communities or with our patients or our own populations, without, you know, even maybe knowing it fully, or you know, obviously not wanting to or intending to do that. So I think that's an important point. I want you to do one other thing. I want you to, you have the diagram that I gave you. Yes, you do. You have that diagram. And I want you in some small groups to start to think a little bit about this. I want you to think about how you might begin to support a response to stigma in your current role here. I'm thinking of the commission, but also the people who are there in your current role as community members or providers. And yeah, where would you start? Like, what do you think is the most important thing to start with? And if you're thinking about resiliency factors, what would you do? How would you even start that process? I want to show you one other real quick thing, and then again, as we do this more and more, we can actually look at these a little bit more closely. But what I showed you with that diagram, the first diagram that I showed you, was a little bit more global. That was a little bit more like, okay, how could you do this kind of in a global way? But the other way that you might want to look about like having a response is you might want to just be more intentional about a particular issue, like along the continuum. Like you said, okay, you know what? We have an issue. I'm just going to make this up. I don't know if this is true. We have an issue with young, black, same-gender loving men, or MSM, in our particular health district because they aren't accessing PrEP. Like, that might be the problem that you feel like you want to kind of connect the stigma to. And then you're going to look at data, like, okay, what's the data say? What's the disparity that's around that? And then you're going to identify, why is that so? What's the reason why young, black MSM are not accessing PrEP? And you're going to keep going out a couple of times. So let me just show you what I mean. So you might say, you know what, here it is. So, and I gave you a handout for this. You know, black MSM are not accessing PrEP. I don't know what you would say to this, but you might say things like, you know, there's fear of judgment in the community. That's why the people aren't doing it. You might say there's discomfort with the medical providers. You might say that there's something else. And then I might say, well, why is there discomfort with the medical providers? Why are people discomfort with the medical providers? Or people might say they don't know services. So you're going to keep going out and asking, if they don't know about the services, there might be the healthcare services in the area don't offer PrEP. And they say, why doesn't the healthcare services in the area not offer PrEP? Providers have been reluctant to offer PrEP to particular clients, so people aren't doing it. Why are people not doing that? The values of the community regarding people who are at risk for HIV are such that people are not coming in. So you can do another kind of analysis, and the way that's like a root cause analysis that we're doing. And if you do that, then you might be able to think, okay, so what do we want to do? We know that it's stigma, because you can say, you know what, it's really about stigma. Let me just show you. It really might be about the social stigma in the area, or it might be about the internalized stigma that people are feeling about being judged. But what do you want to do to change that dynamic? So it really may not be that you're doing a full-on, we're doing it on stigma, but you're doing it on how do you change the values of the community around people who are at risk? Or you're looking at how do you make providers not be so reluctant to want to offer PrEP. So that's the in, on how you do that. And that's specific, and it might be specific to your jurisdiction or your health district. So you might say, you know what, this is a disparity that we really want to work on, and we really want to do more of a root cause analysis about that so that we can actually change the dynamic of the stigma that's happening in our particular area on this particular topic.